This is a little bit of a hot take, and this is what I want to get y'all's take on. Boarding is messy. Boarding is loud. It's hard to find places for patients. But when your emergency department is full, are your shifts now actually harder because of boarding? Or is it just a little less convenient and looks a little messier?
For me, it's kind of a mix. I don't spend a lot of time like looking at the board and counting the number of boarded patients, but to me, it's where you get the symptoms of your department being on boarding is your ED patients might have a delay in their care because their nurse is working with an inpatient patient, where they're doing floor orders, which are significantly more extensive, more labor intensive, and they're taking away from your ED patients. And so that's one symptom that I feel on a pretty regular basis is even the nurses that I work with are being pulled in both directions, where their assignments are split between boarding and not boarding patients. And then again, I think the biggest issue I have is sometimes I'm being asked to see sick patients in unsafe spaces. And so whether that's in one of the vertical care units, which for us is we just turn our triage into this big, massive kind of chair system, and you'll be seeing septic patients in a chair with no place to put them in the back, and there's really no easy way to do exams. And so again, it's one of those where I don't count the number of boarders. It doesn't really change the total temperature of my shift, but I can feel at times the heat from my nurses are more stressed out. Sometimes I'm being asked to see patients in unsafe places, and so having to advocate for that patient to maybe get a hallway bed in the department versus a chair out front. And so I think there's just some symptoms that if it happens every day or happens, most of my shifts could lead to some dissatisfaction with the whole boarding situation.
And Drew, I want to get your take. I mean, Andy, I'll be honest. If I show up and my pod has 10 beds and 9 are boarded patients and I get a couple hallway patients, there's the mess there. I think from the patient perspective, boarding is all negative, right? No patient wants to be admitted to a hallway. No patient wants to spend their whole time in a chair. But if I'm being, honestly, a little selfish, 9 boarded rooms, 1 open room, and a couple hallway beds is actually easier to get through a shift if that's my clinical assignment as opposed to 10 beds that I'm flipping a couple of times. Drew, what's your take? I mean, is there a version where we may hate boarding? We certainly hate what it does to patients, but does it actually make our day-to-day jobs more difficult?
So I think where we are right now, we're on a precipice of boarding becoming a different issue. So now hospital systems, including the system that I am working in and that I am in meetings for, are saying that boarding is an issue that isn't going to go away. So now we have to figure out how to manage it better. So the conversations had been, can we stop boarding? Boarding is a disaster. How can we improve hospital throughput? And I would agree with your assessment. As of my last couple months on shift, if I have a quarter or half of my beds on the pod that I'm on occupied, then I'm only operating at half capacity or 3/4 capacity of what I could do. That's going to start changing because the metrics that define emergency medicine in what the administrators of the hospital and hospital systems care about are productivity, left without being seen, and patient satisfaction. And if we don't tackle boarding in a different sense, which is finding alternative ways to care for the patients walking through the front door, our metrics continue to get worse, and we look worse in the eyes of the administrators. Now, boarding is not an ED problem. Boarding is a hospital problem, and the hospital needs to get creative, but we have to be a part of that solution because like so many things in medicine, particularly emergency medicine, if we're not at the table and we're not actively finding solutions, then we're going to get told what to do, and what we're told is not going to be the best option.
Yeah, I'll echo Drew there for a second in terms of my hospital system is where I think Drew mentioned his hospital will be going, where our metrics don't change when we board, so I still have to see so many patients in a shift, whether they're in my physical plant, whether they're in the physical side that I'm scheduled to see patients or it's out in the lobby or in one of our flex spaces. And our left without being seen, we know goes up substantially when we board, and that number for what's acceptable doesn't go up on the day we board either. So we're not getting credit for attempts. We're still being held to the same standard, which is left without being seen is less than 1%. And then, of course, our door to disposition, our door to dock time, all those things don't change when we board, and it makes it more complicated when I can't see them in the space that I'm supposed to.